Morning, everyone. So this week we're going to touch on the lower extremity muscles. I group them into what are those things need to do, what is happening in that area, and then what do we need to do in that area. And so when I got right into it and I go into the lateral rotator group, and what that muscle group does, it actually moves the foot outward. So it brings the foot to the outside. So it brings it outward, the foot, not the hand, but the foot. So these and so that's one function that happens actually up in the hip. It's an interesting, place when you think about you're turning your foot out and it happens up in the hip, the functionality wise. But that's one of those ones that's a little bit goofy that way. So that's out of the way. Then from there, what else we got to do with this hip? Well, we got to swing the leg to the outside. We gotta be able to abduct. That means you bring it out to the outside. You got to be able to do that. And so that muscle group that accomplishes that is both the gluteus medius and minimus, as well as the tensor fasciae lata as well, and the gluteus maximus a little bit. So those muscles basically are all going to be attached in this crest area on the sacrum area, and then go down also to the greater trochanter more on the outside a little. So when they pull on it, it like brings the leg to the outside. So let's do the finger thing and see if that works. So they're all attached. Oh, God. They're all attached in this area up in there, and then they go down to the greater trochanter on the side. And what they do is they bring that leg outward like that. So they move the leg. All right, good. So let's do it this way. Okay, so we were talking about the piriformis, the lateral rotator, and then we're now going to the group that abducts, that's mostly attached in this area, again, medially, and then moves into generally the greater trochanter, and a couple of them, the tensor fasciae lata and the gluteus maximus, move down into what we know as the tensor fasciae lata. And you can see that here. You see that white band here? That used to be known as the fascia lata. Now we actually know it, we know it as the iliotibial band, because it goes from the ilium up here down to the tibia, to the lower leg. And it anchors both this muscle here, that's that tensor fasciae lata muscle that I mentioned before, as well as the gluteus maximus in the back that reach into the back of the body. So you can see how a muscle attached in the midline here going into this outside band, and a muscle attached here in the front going into this outside band, how when they contract, they pull the leg outward to the outside. So they abduct that leg. And so that's those muscles doing that. So we're you guys learn these names. Everything sort of up here is the glutes. So you probably already know a little bit about the glutes in terms of the naming. And then we have a few of them. When you see the word maximus, that's the big one. And actually, it's interesting. It is the big one, because you can see it here because it's overspanning everybody else. So it's pretty fat at the bottom. It's pretty strong, because besides pulling the leg to the outside, the other thing it's going to do, if it only contracts alone without this contracting, the TFL, it's going to bring the thigh backward, and it helps in extension, in pushing off sort of the thigh a little bit when you run as well. And then the other ones I mentioned were the gluteus medius and the gluteus minimus, and you can see how they more go from the side of the hip to the greater trochanter in here, and how that then can bring the leg towards the outside. And then the tensor fasciae lata was this muscle here in the front that sort of works kind of nicely with this back muscle. I have an interesting video in clinic of working on one of those, and that changed a lot of the function. Anyway, so that brings the thigh outward and also a little bit back in terms of the gluteus maximus, and then from functionally. So we got that covered. So we have now the foot going out, the leg going out. Now we need to bring the leg back in. That's another thing that we need to do. And now we also need to bring the leg upward, and we need to bring it backward. And that pretty much then covers all the motions that we need to do in here. And so when we look at the bringing the leg up, we're looking at hip flexion, and that's where we go right into mostly looking at the psoas muscle that's attached in the front here on the spine. This is the front of the back of the spine. If I have to work this, usually I work it in here on people, but you got to go through all of that and be basically at the back of the spine. This is where all the guts and all that stuff. And then here on the side also is a muscle attachment, and is known as the iliacus muscle, because that muscle starts in the iliac fossa. And so that's the naming on that. And then they both go and anchor right into the inside thigh. And you can see them right in here as they come down. If they contract, they're going to bring that leg forward and up. And they raise up the leg or the thigh. And so that's what that muscle group does. I always remember that because I teach it with the psoas, radiates back to the back and the butt a little bit. So I say the psoas gives you a sore ass. And so nobody ever forgets that muscle. And it's a really important muscle because this is the one when you get out of the car and you go like, oh, you're going to stretch out the front part of your groin area. That's that muscle group that is responsible for that. So a lot of sitting, creates problems with that muscle. Because if you don't move it. Did any of you guys listen? I'm sorry, I sent you a whole bunch of stuff yesterday, but I text you. Did any of you guys listen to that NPR segment on sitting and on getting up and posture stuff? No? Check it out.
I didn't have a chance to.
Yeah, it's only 10 minutes. I know there's a lot of stuff. But and then the TED Talk is only 5 minutes, and it's like a cartoon that shows exactly what we were talking about. That I thought was great, if maybe for the kids or so, because it's one of those things I feel like we have to be a little bit more on it with all this technology and looking down thing, and these things that I sent you really seem to support that thinking from a medical perspective too, like a corporate productivity and stuff like that. So that's not unserious to think about. Anyway, but you're well weaponed now, so you're all good. So the psoas can give you a sore butt, a sore ass, and what it does, it lifts the thigh up. That's its motion. So that's the hip flexion. So together, when we look at the iliacus from here and the psoas from the spine, we call them the iliopsoas muscles as a combination, because we combine them often in anatomy because they go into the same insertion. They go into the lesser trochanter of the femur. All right, so that's cool. So now let's see. We brought the leg, the thigh forward. Now we have to extend it. We actually already talked about the extension muscle. I mentioned it up here. It's the gluteus maximus that does a lot of that motion in terms of bringing the thigh back. As when we push off. Yeah, I can't do that. When we push off. And the thigh extends, that's the gluteus maximus that does that. And then as we actually keep going in the walking direction, the next group that we can think about is now in the knee department. Now these muscles are mostly going to be attached around here and go past the knee. The hamstrings are the ones that flex the knee. And if we look at knee, we really mostly going to look at flexion and extension. It's kind of like the elbow that way. That's sort of the main thing. And so the knee, the hamstrings are attached to the sit bone here in the back, and also a little bit on the thigh for one of them. And then they go to the outside as well as the inside of the below the knee, because they're moving on the knee. So this is another thing. You always think when you look at these things, this is a picture book discussion. It's not really reading a textbook discussion, because you want to visualize it. And it's a little easier with the pictures. But you look at which joint does the muscle cover or cross, and then that's the joint that he probably has executing a motion on. Now, this you could argue it covers this one too, but it kind of has to go uphill and then cover it. So it's probably not going to be that effective on that. Some muscle cover two joints. Like in the upper extremity, we have the biceps brachii. It goes from the shoulder blade, essentially, covers the glenohumeral joint, and then goes past this elbow joint. So the main motion that does is flexion and extension of the elbow, but also a little bit of that motion, slightly, because it goes to back up here. And so you have that in a few instances, but mostly a muscle works on one joint. And so here the hammies work mostly on the knee joint from the outside and the inside. And then when they contract, we're bending the knee nicely. Now, these are another one sitting. They're always tight and they always give us grief. And so we have to figure out how can we stretch those, or are they needing to be stretched? And that's why it's part of the injury prevention examination evaluation, stretching the hamstrings, because that's the hamstrings shortens professional careers all the time because they're tight and they're not supple enough. Because the problem is you're when you look at this is not a bad picture, because when you look at the fascia, the connections between where then the muscle tissue is inside of those connections, those pockets of white stuff that goes from bone to bone and goes through the whole body. When you look at the hamstrings, they are crucial in the part of that fascia that goes down to the ankle or the foot, the sole of the foot actually, and then up the butt and up the back and into the neck, into the forehead. It's all connected. And anywhere along the line you got excessive tension, it's going to do something somewhere. And the hamstrings are both pulling hard a lot of the times, because they're tight in a lot of people. If you can't bring your leg up 90 degrees, really on your own, then you should stretch them. If you can lay on your back and lift up your thigh by 90 degrees, and you can do it on your own, you're probably all right. But if you have to push it, then you definitely need to stretch it. And do gentle stretching if you do stretching. Whenever something hurts, give me a shout. We'll talk about it. And don't overdo it. But anyway, the hamstrings are important because they can tear themselves, but they also pull on the back. And a lot of people with back pain, you can help them with working on the hamstrings. And that's one of those places where you can think a little and go oh, that's interesting, because, it's if you have good hands and you can work with your hands, you don't need a massage degree to figure out what to do with your loved ones. And I often take my patients who, or my loved ones who face down. I mean, they don't have work done, otherwise don't do it. But, look at all these trigger points. All these X's here are trigger points. These are all tension points that create pain patterns in these areas. So if you have pain in these areas, you could be that this is because your hamstring has not been moving enough, and it's got stiff in there. It's got old blood in there that doesn't want to move around, and you got to basically get it moving. And so one of the ways to do it is stretching. One of the ways to do it is applying pressure points, if you're good with that. I actually lift the leg, the foot, the ankle, and have one of my thumb or so. I like to work with my thumb because I can feel the tension points, or fingers sometimes. And then I go along the line and I feel, where is it tense? Where is it tense? And I move the foot up and down and rotate it and feel where is it pulling. And then that loosens everything up. And you'll be surprised how much you can accomplish by the knowledge that you're attaining if you have the proclivity to like to do stuff like that, of course. Anyway, that's the knee flexion. That bends the knee. And now every bend with knee, we're going to extend the knee. We're going to straighten it out. And that's your good old quadriceps. That's the quads. These are the big masses in the front of the thigh. These are the strongest muscles in our body. Look at this massive, massive stuff. Because look, it's interesting. This is an interesting picture. This is a cross section. And you see how this is the femur right here. And you see in the back, it's a little pointy. And where it's pointy, that's the linea aspera. Is that right? Yeah. That's where we attach a lot of these muscles. Like even the front muscles are attached back here, then reach to the front. The vastus medialis and vastus lateralis here. They do that way. And then they go from the back of the thigh and move forward into the kneecap, and then on the kneecap into the tibial tuberosity from there. So sometimes we call this sometimes it's like they call this the quadricep tendon, and then technically this is called the patellar ligament. But it's really just an extension, and the patella is a bone in between, because a sesamoid bone is in a tendon to adapt to the movement, to make the movement pattern smoother. And the reason why we need to do that, so if you think about it, if you got I do that in class sometimes, but I can't really make the thing. So you gotta, let's see if you could do it. If you gotta, I can't do that. The leg goes down like that. This is the femur. This is the the knee part, and it bends like that. And so what happens is if the quadricep are up here and they have to go to the lower part to right in here to attach to the knee to straighten out that knee and extend it. But this is a 90-degree angle right here. That's way too steep. And if it's that steep, you're not going to be able to oh, look, here it is, duh. If it's right 90 degree, if it's that steep, you're going to have to push a lot, and create tension to make a lot of tension before this knee is moving, because first you're going to push it into the other bone. You pull it on it, you pull it into the other bone. So when you have a patella here, what you're going to do is you make a rounding in here. And if you make a rounding in here, you can then pull a little bit less before this starts moving, because you're not yanking the tibia into the femur first, and then all of a sudden it jumps. And so you can gradually increase the force you exude on the quadricep, and you gradually have the tibia move with it, because the patella, the kneecap, that sesamoid bone, that hard thing inside that tendon, is helping smooth out that rounding to help the motion. Does that make sense somehow? It's a little complicated.
Yes, that's good.
Because it doesn't have to be so complicated. It's kind of intuitive when you actually think about it. We have in the shoulder is a little different. In the shoulder is kind of, actually, I've never thought about it like that. In the shoulder is kind of interesting. We got the deltoids that are attached to and then go right into the deltoid tuberosity. So if they only contract, it goes like that. It don't move anything like this. You have to have the supraspinatus back here that goes out and goes and hangs on the attaches to the outside of the arm that way, and first pulls it out, and then the deltoid can move. So in some ways you can think that supraspinatus is a little bit like the patella in helping the motion. But the other thing, which the top one is interesting, is that that's often where we get I told you last week, that's where we get the rotator cuff injuries, because we're overusing that muscle over time. Anyway, that's kind of biomechanics. Yeah, I like this stuff. I'm sorry if I'm too blabby about it. You can tell me if it doesn't make sense. Just ask questions, interrupt me, or tell me to had enough. The next motion that we do want to still talk about, we brought the thigh out, but the femur, but we haven't brought it back in yet. And so we're going to add the duct, the leg that's still hanging out here, because gravity is going to do some of it, but depends on the positioning. So, this is really great, because these muscles are generally just called the adductors. So the adductors adduct. And if you're still confused with adduction and abduction, welcome to the club. I don't know who thought of these two words being useful to do that with, but that's what they did. And so adduction, I always remember, ADD is what I have, but it also means adding something to something, and adding a limb back to the body and bringing it back in. To me, I can remember adduction as a word that way. And then AB is just the other one. Anyway, so that's one of those goofy ones. But these muscles are all attached on the back of the thigh, which is the linea aspera. And then they go either to the pubic bone, to the front of the pelvis, or to the sit bone in the back. And it's kind of sensible, because if you think about the pelvis, the front and the back are, they're a little bit apart from each other. They're not, I don't have a lateral view. Do I have a lateral view? No, I don't think here. They're a little bit apart, front to back from each other. So what you're doing when you bring muscles from the back of the thigh and you go front and back, you kind of fan them out a little bit, and that gives you great protection and medial, pulling in. But that's the zigzagging motion, pushing the leg in like that helps you stabilize the whole thing. So these muscles are massive. And so we got some of them go to the pubic area, and then some of them go to the sit bone. Actually, the one goes to the sit bone for the most part is the adductor magnus. Oh my God, there's a mistake in here. Okay, because the gracilis actually goes to the pubic bone. This is correct. See, there's one muscle. So all of the other ones, so the adductor magnus goes from the linea aspera mostly and a little bit here to the sit bone and holds the thigh more backwards a little bit, adductor posterior. And then the adductor brevis and longus, these other ones, goes to the pubic bone and attaches right in here and anchors the thigh a little bit, brings it adduction a little bit more forward that way. You know, you got to think, like yesterday was, I guess it was a good football game. I didn't watch it, but if you watch McCaffrey ever, he zigzags like crazy through the field. And one of the muscles that was one of these muscles that I was working on him at some point. And he, of course, knew exactly what I was working on, which is great. He was 18 at that time. And so that's how you use that muscle when you want to run side to side kind of thing or stabilize side to side. So that's why they are so massive. One other thing that's a mistake here that I've probably took over, and I don't know what happened there with my brain. So the gracilis also goes to the pubic bone. You see, this picture here is correct. The gracilis goes to the front. This picture is wrong. The gracilis does not go to the sit bone back here. And, you know, that's, although you see how it comes around. So it sort of reaches around. So, you know, maybe it's a little bit technical on that. But anyway, sorry, I just found another thing I can improve on. So we now brought the thigh in. We brought the thigh out. We bent the knee and extended it back. We brought the femur, you know, the thigh up and back. We did everything that we kind of need to do up there. We have one left. And that muscle is the sartorius muscle on that area. And that muscle is attached to the ASIS. That's where that comes in. And then it goes to the medial, supramedial shaft of the tibia here. And what that muscle does, it holds the leg in. It crosses the leg over to the opposite knee, basically. If you cross your legs, you use that muscle to cross your legs and guide the motion. It's an interesting example because it's a small sliver of muscles. It's not going to be doing all the stabilization of all those positions it's going to put it in. That's done by all these other muscles we just talked about, but it has the ability by its attachments to do those motions and guide that leg over. You can see here how you can see other muscles working as well, how the adductors work, how the psoas work. This is actually a nice picture in that motion, but you can see how that muscle kind of guides that motion and brings that leg over to the opposite thigh. So that's the sartorius. And of course, it's a beautiful name. Guess what? It's on the, oh, never mind. Sartorius, talar muscle. All right. Then from there, we basically going to be almost done. We're going to go us to the calf. And we're not going to go to the foot. I mean, we're going to go into the ankle, moving the ankle. We're not going to move too much of the foot around. Because that gets really complicated when you go into the foot and to the hand. But it's very interesting, but you can always look that up, or we could talk about it if you have interest. I made a lot of, if you ever want to have more knowledge on those things, I made plates where I wrote the name into the muscle to have it easier to be visible and accessible. Actually, while I'm doing that, let me show you real quick. Safari. There you go. Because if you go into these, yeah, and see, last week I was lecturing. Yeah, you could tell me if it's better lecturing with the PowerPoints or with these pictures in here. Anybody, that would be good feedback because I'm just playing with either or. Please. Anyway, if you go into the lecture, what I wanted to point out are these things here. We talked about the cadaver videos already. So you have every muscle has clipped, specifically I clipped them, the part that talks about that muscle out of a long DVD thing. So it's not, it's like a minute or so, it's not long, but it really visualizes things nice. Has anybody been using those videos? Then this is a great thing for flashcards. If you like to have flashcards, it shows every muscle individualized that we need. So you can, or just color it, you know, to study. That's also cool. And probably download as a PDF, you know, you don't have to print it. And then this is the one I want to show you. I think I did it once before. So this is a mostly electronic because it's all the muscles. It doesn't look like that many, that we kind of need to know, or that I need to know applying all this stuff. And so you don't need to know all of those because I made this for me, but it's in electronic format. So you can zoom in and you can go like, what are we doing today? We're doing, look at that. We're doing the adductors. And this is the anatomy atlas. Look at the gracilis we were just talking about. See how it goes to the front of the pubic, and the other picture showed it more like down here. So it's a little bit removed. And so you can really see the attachments and the line that sort of is usually what obscures the understanding of the muscle a little bit. So this picture is, and then what I did is I wrote the name in. Obviously, it's my writing, so some of it's a little bit, but as good as I could, because I couldn't figure out how to annotate it yet. Now I will be better at it. Was typing, but this is a great picture. I think if you have an understanding of this or want more, or if certain things don't necessarily make sense, to look it up if I talk about it. Anywho, that's for that, just to make sure I don't forget that. And now we're going to go into the calf. And when we look at the calf, we're looking at a few motions. We're looking at having to bring it up and down, and then we need to bring the foot also out and up and in and up. So we need to do this pronation, supination kind of stuff. Actually, it's called, when we look down in here. And so when we, what's the word we're using here? I'm a little flabbery here. All right, eversion and inversion. So eversion and inversion are the words that we're using for that. Sorry about that. I'm a little slow with that this morning. So anyway, when we go now into the ankle, we first want to look at flipping it up and flipping it down. And especially flipping it down, bringing the toes into the ground in plantar flexion, because that's a very strong motion. That's actually been tested when we do the squats in our injury prevention eval, if those are strong enough, because they're anti-gravity muscle. They hold us up against gravity. And we have 3 of them. We have 2 that are known as the gastrocnemius, and they're attached here and here on the femur. And then they all go into the calcaneus in the Achilles tendon. And then the third one is not reaching over to the femur. So this is interesting, right? Reaching over to the femur means it crosses 2 joints, means it's gonna do a little bit of motion at the knee as well, just not much, because it's very weak up here if you visualize where the belly of the muscle is. Kind of. But then the soleus is underneath that, and the soleus is attached here on the fibula and on the tibia. So it's below the knee, and then it anchors into the calcaneus. And it's actually the stronger one of all of them. It's a really thick muscle underneath. And you can see it a little bit more here, how thick and wide it is. And that's known as the soleus, because I guess it looks like that, the sole fish or something, I think. Anyway, that's what I learned originally. Didn't make too much sense. The interesting one of that one is, though, it has a lot of blood vessels go through it. So if you want to get the blood moving, it's good to push the foot into the ground and sort of, do stand-ups like that and get the blood moving from the feet. And so as you see, like the British Guards or the ones in Rome at the Vatican, they kind of do that because, they have to stand all day. And once in a while, somebody falls over because there's not enough blood going to the head, because blood has a lot of iron that goes down to the ground. So it's a little heavy. So anyway, that's an interesting thing about the soleus there. But that really pushes the toes into the ground very nicely. And is very forceful and strong. And, it has to lift up our weight. So these muscles better be strong. And then underneath that, in the back, let's go to the back first. Sorry, there's the back. When we take that away, underneath that, we have 3 muscles. We have a tibialis posterior, right in here, mostly attached to the tibia, a little bit the fibula. And then you look at where that goes nicely here into the tarsals on the bottom of the foot. And so when you look at what that does, it does ankle plantar flexion. So it also helps pull from in here, pulls it up, and that pushes the toes down. So it helps the gastrocnemius and the soleus. And actually, gastrocnemius and soleus together, we call them the triceps surae. But, there's gets a little much with the terminology. And then we also have back here a muscle that is, look at that, flexor digitorum longus and flexor hallucis longus. We learned that the toe, big toe, is known as the hallux. So this is probably a muscle that flexes the hallux, that pushes the hallux into the ground. And this does the same with the toes over here. We don't have these on the test, but what you want to be aware of these, what's interesting, if you look from this picture, it makes a little bit more sense that way. The muscle that is on the medial side, that where the toe is actually, is on the medial side of the leg. And the calf is really the leg, and the thigh is really the femur is really the thigh when we look at that part of the terminology. But that's the side that the flexor digitorum is on, and digits are the toes, not the hallux. And so what happens is that muscle goes, and then underneath, it goes underneath to the outside. And the other muscle, the flexor hallucis longus, starts on the outside and moves over and crosses to the big toe, and then does the flexion that way. So when you do the homework, watch out for that. That's a little interesting. And so it crosses right in here behind the medial malleolus, where it crosses over. So these are not on the test. These are on the drawing and labeling stuff. That's important there. To understand them, but then labeling, if you see this on the back, you just know it's the tibialis posterior, or of course the gastric or the soleus, but if they're taken away. And then interestingly, let me see if I have a shot of that. When we are at that level, at the deeper level of the leg, we have three compartments. We just talked about the back compartment. And now we talk about the front compartment, because the front compartment is the same as the back compartment, it's just in the front. So it's now known as tibialis anterior, now tibialis posterior. And instead of pushing down, which is flexion, now we're bringing it up, which is extension. So we call these the extensors, digitorum or hallucis. And so that's what we see here. This is not the same system as crossing over. This is going straight down. So in the labeling, you're going to see the muscle that's on the lateral side is the extensor digitorum longus, and the one in the big one on top here is the tibialis anterior. That one is really, really strong, and also very important. It goes right into here. A lot of times when people have wobbly ankles, this is very strong and very, very sore also. And then the fibularis, which we do next, also that's on the outside. But then underneath it, you have the extensor hallucis, and that sort of comes out here as the purple one, as you can see. And these are the booklet pictures, as you can see here. And so when you label, these are good ones to copy from, sort of, to understand that a little bit better. And then my favorite is the lateral compartment. The reason why I say my favorite, because clinically this is very, very cool. Because this muscle is known as the fibularis, which makes it easy to remember, because the fibularis attaches on the fibula on the outside, sort of outside and backside a little bit. And then here on the other side of the fibula, between the fib and the tib, is where we have the tib anterior. But anyway, and sometimes they still call this the peroneus. See this word peroneus? That's the old word for fibularis. But what's interesting about this one is the longest, is the longest one. Longest means long. We have a brevis, and then we actually have a tertius here. See the word tertius? But they're just along the line here. And the longest is on top to the middle, and then the brevis is lower, and then the tertius is a sliver. I think not even everybody has the tertius, although I'm not sure about that anymore. But the interesting thing is the longest goes underneath the foot. So it reaches underneath the foot. See where that tendon disappears? That's the tendon. It goes underneath the foot. And if you have a twisted ankle, you flop the foot this way, you stretch this muscle, and then that muscle becomes wimpy. But the problem is, when you flip your ankle over too badly, you're also going to stretch all these rubber bands that are here, which are the ligaments. And when you do that, and the muscle is sort of floppy too, you have a floppy ankle, and you're going to floppy it all the time. And I have people that, they can hike again, they can do stuff again, but they're still getting tired on that thing more than others. And then when you go and you actually find that muscle, it's not working. It's like dormant. That muscle, if I put it in a position where it can test it and it goes, nothing holds. And it's very interesting. And you can do a lot of good with working on that muscle with people who have twisted ankles. And you don't have to know, again, this is one, if you go with your hands, you can actually go and go behind that fibula and work that muscle and just sort of rub on the attachment and do it, so it burns a little bit, but it's not too hard for them that they can tolerate it. I wouldn't do this. I don't know what I have. Oh, actually, I mean, it's a good move, but it shows me because of the fibula. Yeah. But I don't usually use the elbow. Some people are really good at using the elbow. I use my fingers, but because they can feel better. But this is a very, very interesting place to help people a lot. You start up here and you just move down, and it sort of gives a little more room to this tendon, and it hurts less. Anywho, that's about all I have to say because, we did the posterior compartment already. Then, any questions to that, or is that still pretty okay?
I have a question.
Please.
But it's more on the injury prevention. I don't know if
let's go there.
Or stay on this.
Let's do that. That's the next thing here.
Okay.
Go for it.
And this, it's actually kind of a personal thing. So
want to do it offline afterwards, or
no, it's just explaining one of my sore muscles.
Okay.
I don't know if people are interested in that, but so yeah, it's asking you a question kind of professionally. But also to say, so the injury prevention was really interesting for me, so my knee, I always kind of have my right knee always cracks and is a little sore and stuff like that. And then I noticed probably my soleus, so the muscle, on the back of my calf, so probably the soleus muscle, was a little tight. And then the other day I was just walking and it felt like a tear. And now it's really sore. And so I thought it was interesting. The biomechanics of the prevention injury booklet said, if one thing isn't working right, then maybe the things around it will kind of be affected. And I wonder if because, my knee has been bothering me and all of a sudden now, it's the back of my calf muscles. So that was just a comment saying this injury prevention is coming at a really good time for me personally. But then also, and
I don't know if you have difference in balancing.
Yeah. So I do. My right side, my right hip doesn't feel as good as my left hip. I mean, I'm 57. So I feel like there's a lot of things on my right side that have never worked so good. So yes, my balancing is different when I'm on my right foot or my left foot. But so for this really sore muscle, the soleus, what I think muscle on the back of my calf, is it better to massage it? Is it good to put ice on it, heat on it? I need to walk my dog. Should I not walk my dogs and let it rest, or just still kind of like doing small walks and stretches is good?
It depends on the level of pain, obviously, of how much you do. You can use ice. I would use warmth to warm it up in the morning, and ice to cool it down when it's hot, when it hurts, and then after the activity, and the ice you use I use the mnemonic C-band. It's called because how it feels when you apply ice. You always apply ice over a towel or so, not directly on the skin, so you don't get skin burns. And you don't leave it on for more than 20 minutes. But you put it on, it feels cold, then at some point it burns, then at some point it aches, and at some point it gets numb. And once it gets numb, you take it off.
Okay.
So that could be 20 minutes or it could be less than 20 minutes. If it's 20 minutes, you take it off anyway. And you do that once every 2 hours, not more than that kind of thing. Because somehow it has to do with the vascularity. Does it go to the area? Does it take it away? And once the body perceives something as too cold, it brings vascularity back to the area when we actually like to numb it right at that time. Because it tries to protect it from that. And so that's one thing you can do. I would I would be gentle in terms of, it's tissue that's, if it is most likely in the muscle somewhere, it has a lot of vascularity going to, so it will heal fast and
Okay.
nice that way. If it's if you use it gently, not overuse it, but not use it, because you want to tell the body where you are, what you're doing, bring the
Yeah.
oxygen to that area, but also bring the stresses a little bit to that area, so when it has to do some healing, it knows how to do the healing.
Okay.
Right. So walking a dog is probably a good thing. Just
Okay.
don't go to the excruciating level and stay below that. If
Yeah.
you do medication, I wouldn't do too much of that for too long. If it's ibuprofen, a couple days, but then you want to have the body help the healing and not suppress that healing part.
Yeah. Yeah. And it's not
Anti-inflammatories.
yeah, that I can't really handle. It's more, a discomfort, which I don't mind living with as long as I'm not making it worse. You know what I mean? Like
Yeah,
in a week, I don't want to say, oh shit, now it's so
that's
much
right.
worse. I shouldn't have done this. So yeah.
That's
Okay.
right. That's where you want to stay within that window. And those
Okay.
are things that all of you can learn from, because that's really how you can work with a lot of those kind of injuries. You want to be gentle and not overdo it, not feel like I gotta push through it, and that you can maybe get away with it in your 20, but we're at 50, so we don't get away with
Yeah.
it.
Yeah,
It just
exactly.
takes a little bit longer, but you still always work within that framework, doing something, telling the body what needs to happen in this gravity field again.
Uh-huh.
And the collagen knows how to lay down to heal versus
Uh-huh.
resting it and recuperating it. And
Uh-huh.
then the other thing is, when it comes, let's say you get into the strengthening phase and you want to go to the gym, let's say, I tell people do low weights, slow movement, and not end range.
Okay.
And then that's
And
pretty safe if you think
yeah.
about
What
it.
does end range mean?
And like, this is range and then this is end range.
Oh, okay. Okay.
Don't go all the way up. Go to here.
Okay.
Right, for
Okay.
example. All right.
Okay. Yeah.
Cool.
Um,
That
wait, so
help?
you said, yeah, that's very helpful. Thank you. You said collagen. Is collagen for bones and muscles? Because
Everything.
oh, it's for everything. Oh, okay.
Collagen is in everything. Collagen is the super glue of our body.
Okay.
It's got a long tensile strength. So whenever we need to have fiberglass patch things together, do things, holding together things, we use collagen for that.
Okay.
And
So
that's
would it,
one of the challenges with a lot of more chronic pathologies of what's developing with the sedentary lifestyle. The collagen is not that strong.
mm,
Like elder Danlos has collagen stuff to do. I'm sure fibromyalgia has collagen stuff to do with it in some ways. Just I
so
don't know.
would it be helpful to take a collagen supplement? Because you can buy these, that you
I
put.
know. I'm not totally sure
Okay.
how good absorbability there is. I've been hearing that liquid formulated are better than powdery type
Oh,
formulated from absorption
okay.
perspective. But then I got these people, the new something they want to, they always want me to sell stuff, and I don't sell stuff.
Oh,
I'm
yeah.
not, I don't like, I'm not good at selling stuff, and I don't like it. But then it's a price question too. So always with these things, if you read the ingredients and you don't understand any word of it, it may be a bit too
Uh-huh.
chemical. Like with the
Okay.
license, if you understand it's Brussels sprouts, it's this or that, you leave
Yeah.
it outside and it degrades or so in the
Yeah.
vitamin department, and that's probably better products. Um,
Okay.
and then with something like a collagen, I would see, you take it for a couple of weeks. Do you feel a difference?
Uh-huh.
Or
Okay.
see how, or ask, that's a Google question. Ask, how long would you wait till you feel a difference?
Uh-huh.
That's
Yeah.
an okay question, I would think. You
Yeah.
get a few cross answers, and then use
Yeah.
yourself a little pain thing of some joint or so, and measure it.
Or Bard. I've started to use Bard more than Google now. Google's AI Bard. Have you
Oh
used
yeah,
that?
yeah. I haven't
That
used that yet.
that's crazy. I know people who are like planning a sailing trip in Belize by asking Bard, like, what's the best?
BAR?
BARD.
Oh, got it. Okay, I'm gonna go
Uh,
look at that.
and then it
'Cause
does like this
I need an
whole
assistant for my office. I need somebody to do the grading and all that. No, no, don't worry. That's all personal. I
Probably
do
could.
that myself.
Yeah, yeah, yeah. Or your daughter.
No, I do all
Um,
the, yeah, that could, no, but I do all the grading. I try to get
yeah.
through all the discussion posts.
She sounds like a good assistant though, or at least a good student. So that's nice. That's
Oh, yeah,
great.
yeah, absolutely. Absolutely. She's
Yeah,
a sonomo now.
good.
Good. So let's finish up with this week. Well, because we're not doing that much this week. A lot of you guys, this is sort of getting, the last portion of this second test material, and then getting some drilling going on. Hopefully tonight I'm going to do some drilling with you guys who come to class. We do have class. I checked with the school if, because first I looked up whatever holiday came up with Columbus Day, and then this morning somebody says it's Indigenous Day. I'm like, oh God, I don't know. And then I checked with the dean, and the dean said it's open, so we're gonna go. At least I'm gonna be there. And it's not mandatory, but it would be great if you come up. I have a few of you come up. I got some kind bars if you're hungry for you guys. So we're all fed at 6 o'clock if we need to. And we'll finish the injury prevention thing after we do a drill. And I talk about the muscles. I think we actually talk about the arm muscles, and the next week we finish up with the leg muscles in class. Did you guys watch the trunk video? Was that too goofy, or was that all right? Nobody
I
was.
didn't watch
Oh,
it.
well,
Sorry.
I was doing it in clown costume, so we'll see how that goes tonight. But we're finishing up that injury prevention, and you guys at home, just do it home at home. That was a 2 week, and that was on week 7. And now week 8, besides having the lecturing, which we did some kind of just now, and then the extremity, the questions, we have then the labeling. You're gonna know how that works by now. And then we have a new thing coming up for the latter part of this semester, and we're gonna do a pathology project. And so we're going to have 3 people per group that are going to research a pathology of their choice, of the group's choice. So it's a little consensus on that. Often something interesting for one member, extremely interesting, maybe, or have some personal attachment to it somehow. It's usually a good goal. Very often we have back pain, diabetes, cardiovascular disease, anxiety, depression disorders come up a lot too. And then what I want you to do with that is I want you to then, first figure out what you're doing, and then research each group of the 3 members of each member of the group will research a question. Either one member will research what is the pathology, what is anxiety, what is diabetes, etc., cancer, whatever we're doing. The next person will go look around and Google and everywhere on Bart. Well, actually, you still have to present it yourself, so Bart can't do that. What we can do about the pathology, like what medicine does, particularly science and that portion. I mean, that medical science portion. And then the third person will research what can you do to help the medical profession in that thing. And that's often more dietary, more movement, more functionally, medically stuff, and herbally sometimes, etc. That's often a place where we have to learn how to differentiate between useful and not so useful. But we also have to do that with medicine too, because it's very, very we have to have a lot of answers for a single problem, and we have to weigh what's best and what to do. And so what I want to do with that as a whole project, I want to make us more sensitive to those kind of questions, and have an example where we do that with, which is the project. And then once you do that, I want you to create a presentation. Or actually, now I'm still teaching with PowerPoints, but I did a presentation with a pamphlet that I made, a brochure for other teachers to make their classes better. Well, hopefully, or whatever that means, but no more PowerPoint. And so it doesn't have to be a PowerPoint or a presentation. It could be something like you have an electronic PDF that you send to everybody so they can have it on their phone. And if somebody has diabetes, you give them that. Originally, that's what I wanted with this, because I had a student walk in who got her son to the ER for asthma, and they only gave him an albuterol inhaler. They didn't talk to him about allergies or food and stuff at all. And it kind of made me a little upset, because they need to know that if you have a kid that has asthma and you keep feeding him bread and milk the whole time, they're gonna keep having phlegm. And it's not just a question of albuterol, it's a question of like understanding those things, because not everything is an antibiotic at the end. And that sort of made me think, okay, we got to do better than that. And so that's how this sort of thing started. And so I wanted everybody to make brochures, and I had an online product, the brochure making thing from Microsoft, which it was Sway. It was called Sway. I think they got rid of it now. But that didn't kind of work out. So we ended up doing presentations, and then now we do sort of an audio visual video presentation on Zoom, the group, and then post that presentation, and then we connect in a discussion and look at each other's and do two things. We learn from each other, and we also can give each other feedback on sort of the process of doing a presentation. And along the way, I can help you with whatever I've learned in making these kind of presentations, and what flies and what doesn't fly. And generally speaking is, give a lot of pictures and explain the pictures and when you talk, and so stuff like that. So now this is till the end of the semester. So this is a long drawn out project that should be mostly fun. Most of the time the students have fun with this. Last semester in the spring, I had a group. I had two students that were deaf. We did that with interpreters. And I have that video. I can ship you that video. It's really cool. We go into the classroom a few times. If you want to do it in the classroom, we do it in the classroom. I think we should have that now as an option again. That one of the times we go into the classroom on Monday, if your group come up, we do it. We can play with that a little bit, because it's certainly easier in person than on Zoom. But it's also good to know that technology at this point. I mean, things are moving quite fast in all that arena. So the first thing I want you to do is I want you to join a group. And what you do, and I am so not prepared. I didn't expect this to come up. I thought it was next week, but I want you to start thinking about this. So what I want you to do when you do a group, you go into your people thing. And when you have a people thing, it says your groups. Oh, and I didn't do the groups yet. So I'm going to do the group here. And I'm going to add a group set, and it's going to be the pathology group project. And then I want you to go in and attach yourself to allow self-assign. And I'm going to create limit 3 per groups. And I want you guys to add yourself into the groups and create groups that you want to do that with each other. I want you to do that individually, on your own a little bit, so you can, go into the people's profile if you want, because we did that, right? Do your profile thing. You can go in here and you can read and say like, oh, I like to work with that person or so, and you can create groups that way together a little bit if you want. And if it's not, usually it's like, half the crowd, half of you add yourself to a group and do it, and then the other half I kind of help along and just get you assigned to a group when after a week or 2 weeks or so, when you get to the next step. But first of all, you just do a group assignment and get yourself into a group, and then don't worry about this piece of what I just all told you about until after we finish the test. And then we get next week or after that, we get more into the choosing a pathology, and then we start doing the research. All right. So that's all we have on this. And then we finish out with the questions and tips. And with that, we can close it out. I'm pretty much done. I know it goes a little fast, a little chatty today. I'm sorry about that. But any questions? Huh?
No, thank you.
Was that helpful?
It was very helpful. Yes.
Okay, good. That's good. And I'm glad you asked the question too, Andrew, because it's these are very relevant things for all of us, and if you're okay with sharing, I'm okay with sharing.
Yeah. Yeah. I'm getting my husband to do these prevention stretches, injury prevention stretches too. So it's 2 for 1.
Yeah, no, this stuff is this. I do find it quite relevant, those things actually,
Yeah.
and it's actually for the not just for us older farts, but also for the young ones, because a lot of us do the sitting. That's why that NPR posture thing, economic happy level thing, that I thought of your daughter, that
Yeah.
you wrote, that was like very interesting. And then that little 4.5 minute cartoon TED talk thing is like really revealing, because you create the visuals.
Okay. I'll go and look at those now because I haven't had a chance to look at them.
Oh, that's okay. There's a lot going on.
Yeah.
All right. Well, everybody have a wonderful week, and I hope you enjoy the night.
Okay. Bye.
Bye.